being here. And we'll have Dr. Indira Durai from Aravind Eye Hospital, Madurai, who will be introducing us about angle closure disease, the basic pathology and pathophysiology. Over to you, Doctor.
Okay. So good morning, everyone. In this talk, I'll be covering some of the latest developments in the diagnosis and management of angle closure glaucoma. So gonioscopy continues to be the gold standard for diagnosing the presence of angle closure. It provides useful information such as presence of synechiae, pigmentation, and plateau iris. However, this is a highly subjective procedure. Quantitative studies of the anterior segments such as the AIOCT and UBM provide objective measurements. AIOCT is a non-contact procedure which can visualize the entire anterior chamber and can provide parameters for detection of angle closure in a single scan. The recently developed deep learning based digital gonioscopy system, which uses the 3 swept source OCT, has been developed, which stimulates both static and dynamic gonioscopy and helps to detect narrow angles and presence of pus. UBM has the distinct advantage of imaging the posterior chamber and the ciliary body and can be used to identify certain conditions such as the plateau iris and the iris cyst. However, anterior segment imaging cannot be replaced by cannot replace gonioscopy and can be only serve as a useful adjunct. So in PACG patients with progressive GCC thinning on SDOCT, the functional progression was detected much earlier than in patients with progressive RNFL thinning. OCT angiography shows that lower superficial vessel density was significantly associated with a faster visual field progression in PACG. One advantage of this technique is it can be used to monitor progression in patients with advanced glaucoma as it was less affected by floor effect. Choosing a program on standard perimetry is based on the disease severity and macular function. The patterns of visual field damage in chronic PACG is different from POAG. PACG has a more central advanced field defect. So recently the 24-2C protocol has been developed, which adds the 10 central points from the 10-2 grid to the standard 24-2 grid. This enables us to perform both the peripheral and the central visual field testing in the same sitting and can be used in both early and advanced cases of glaucoma. So the mainstay of treatment in angle closure disease is the laser peripheral iridotomy, which eliminates the relative pupillary block component of the angle closure process and is indicated in patients with angle closure suspect, acute angle closure glaucoma, and primary angle closure glaucoma. Considering the larger prevalence of PACS in our population, one question which commonly arises in our mind is, do we need to do a peripheral iridotomy in all patients with PACS? To answer this question, both the ZAP trial and the ANALYST trial has showed that though eyes treated with peripheral iridotomy has shown a significant 50% reduction in the development of PAC or acute attack, the rate of progression was less than 1%, hence they do not recommend a PI in all cases of PACS. However, in certain conditions, like PI can be done, like in fellow eyes of acute primary angle closure, PACS, or patients with poor access. It can be used in certain situations like acute PAC for rapidly lowering the intraocular pressure in patients with corneal edema or in patients with PAC or plateau iris syndrome who do not show an improvement after iridotomy. In PACG, however, ALP is less effective than when compared with prostaglandin analogs. SLT also has a limited role in PACG and shows a short-term reduction in intraocular pressure and has no additional benefit when compared with prostaglandin therapy. So micropulse lasers can be safe and effective as a temporary measure in reducing intraocular pressure in patients with refractory and advanced angle closure glaucoma with a good visual potential, where the risk of surgical intervention is very high. In medical management, prostaglandin analogs have been shown to be as effective as beta blockers in the management of chronic angle closure glaucoma. The surgical management depends upon the clinical presentation. In patients presenting with acute primary angle closure with cataract, Early phacoemulsification has resulted in a better intraocular pressure control and the need for less number of glaucoma medications when compared to laser PI, and when especially when it is performed within a week of resolution of acute attack. So, in patients presenting with a clear lens in PAC or PACG with mild damage, clear lens phacoemulsification has shown to be superior to laser PI and is recommended as a primary intervention, especially in patients older than 50 years old. In patients with medically controlled angle closure glaucoma with coexisting cataract, phacoemulsification alone has been found to be more effective when compared with phacotrabeclectomy, as the latter had a higher rate of complications. Similarly, in patients with medically uncontrolled angle closure with coexisting cataract, phacotrabeclectomy was found to be superior to phacoemulsification in controlling the intraocular pressure, but it had a higher rate of complications. In patients with medically uncontrolled PACG without cataract, trabeclectomy was found to be more effective than phacoemulsification alone in controlling the intraocular pressure, but again had a higher rate of complications. So, in patients with advanced PACG, uncontrolled intraocular pressure and cataract, primary trabeclectomy was the preferred choice. In patients with peripheral anterior synechiae and cataract and mild PACG, both phacoemulsification and phacogonial cyanocolysis has been found to show a significant reduction in the intraocular pressure, but there was no added benefit of phacogonial cyanocolysis over phaco in PACG. Combining cataract surgery with MIGS can be safe and effective in early cases of PACG, but its role in advanced PACG remains unproven. Glaucoma drainage devices in PACG eyes can be done in certain individuals, especially with a sufficient deep anterior chamber angle, or in patients with pseudophakia with a shallow chamber where the tube can be placed in the ciliary sulcus. Thus, to conclude, the rate of bilateral blindness in angle closure glaucoma remains high. A thorough history and eye examination is important to differentiate between primary and secondary forms. It is important to utilize the various diagnostic and laser or surgical options at our disposal so as to optimally manage this condition, so as to minimize or reduce further vision loss. Thank you.